anybody studying this on a systematic fashion, looking at, because obviously you could compare open with ERAS, robotic or laparoscopic with ERAS. You could do open without ERAS. Is anybody looking at that in a systematic fashion, do you know of?
Oh my goodness. I don't know that there are any randomized trials comparing. I think that there's been actually a lot of basic science work looking at bowel manipulation and the release of inflammatory mediators, nitric oxide and the rest of that. And it's clear that the more the bowel is manipulated, the more that these inflammatory mediators are released, which increases the likelihood of developing both hypomotility and edema of the intestine. All right, so from a basic science standpoint, we understand that that's the truth. Now, with respect to is anyone doing a true randomized trial with respect to that? I'm afraid we still are zealots around things. You find people that have decided ERAS is the way to go, and frankly, I'm not sure I'd be willing to step back to do non-ERAS care. I've stopped thinking of ERAS as enhanced recovery after surgery. I think it should be expected recovery after surgery. We need to be following these principles because they work.
I will say that we didn't randomize it, but we looked in our open and laparoscopic cases before and after implementation of enhanced recovery. What we found that is after we implemented enhanced recovery, our open patients were going home sooner and had less complications than our laparoscopic patients did in the pre-enhanced recovery movement. So, you know, there are a lot of people that think if you're doing minimally invasive surgery, you don't need these principles, and we know that is not true. You know, if you take a laparoscopic patient and you give them, you know, a couple doses of intravenous opioids, it'll have the same effect as if it is an open surgery. So I think the two are not mutually exclusive.
And I think if you focus on length of stay and complications, as Traci pointed out, and measure those, that may replace randomized controlled trials as far as how we move forward. Because if your length of stay and your complication rate is still higher than you would like, and you have a protocol, you change one thing as an institution to see if it makes a difference. That's the real power of standardization, at least in private practice, and I think it will be in academics as well. It's hard to get a randomized controlled trial together, but if you have a way you do things and you measure your outcomes, if something impacts your outcomes, then that's the way you do it. Virtually every place where enhanced recovery has been implemented in a system, there have been positive effects. It's universally reproducible because the principles hold wherever it is done, and every place it's been done, length of stay and complication rate has been improved as it is brought into play in the system, and it's happened in a variety of specialties. You know, we in the hospital where I practiced primarily, we started not with colorectal, but actually in complex upper GI, hepatobiliary and pancreatic surgery, because I was the champion and that's what I do mostly. And as we began to develop the system, then we were able to begin to allow the colorectal surgeons and the urologists and the orthopedic surgeons also to begin to implement it. And it was the success in the first area that led to the adoption in the other areas.